Hello everyone and welcome back. So let's revise breast with me. Okay. So first of all, the introduction of breast. Nipple discharge. 7% patients referred with breast discharge. It may be serious blood stains or colored. The blood discharge is one of the most common disorders in breast, and 7% of the patients referred with breast discharge, and it may be serious blood or stains or colored. Discharge from the surface. If it is from the surface, then it is eczema or Paget's disease. Okay. Whenever a patient comes with the discharge of breast, so the differential diagnosis are eczema and Paget's disease. If the discharge is from the duct, then the differential diagnosis are you have to see if it is blood or if it is serous. If it is blood, then it is duct papilloma, duct ectasis, and duct carcinoma. If it is serous, then it is fibroadenosis, duct ectasia, or duct carcinoma. Okay, so discharge from the single duct, whether it is serous or blood. If it is plus blood, then it is duct papilloma, duct ectasis, and duct carcinoma. Duct papilloma, ectasis, and duct carcinoma. Duct papilloma, duct ectasis, and duct carcinoma. If it is serous, then it is fibroadenosis, duct ectasis, or duct carcinoma. Okay, the duct ectasis and duct carcinoma, it can both be serous and blood, but in duct papilloma, it is blood, and in fibroadenosis, it is serous. So this is a differentiated point. If the discharge is from the duct and it is serous, then it is fibroadenosis, and if it is blood, then it is duct papilloma. Now the discharge from more than one duct. If it is from more than one duct, then look at the discharge. If it is blood, then it is duct carcinoma, duct ectasia, duct papilloma. If it is black, then it is duct ectasia. If it is purulent, then it is mastitis. If it is milk, then it is lactation, hypothyroidism, or prolactinemia. Okay, these are the differential diagnoses. So only the breast discharge can give you a lot of differential diagnosis. If it is blood, then it is duct papilloma, or duct ectasia, or duct carcinoma. If it is milk, then it is lactation, hypothyroidism, and prolactinoma. If it is purulent, then it is mastitis, and if it is black, then it is duct ectasia. Okay, now the treatment options. So first of all, exclude the malignancy by triple assessment. For breast, you also have to do the triple assessment, and doing triple assessment, you have to exclude the malignancy. Then reassure the patient, and if the discharge is intolerable, then surgery is done. Okay, so we have a patient of nipple. We have a patient of breast discharge. So we will look at the type of discharge, then we will give our differential diagnosis, then we will investigate and manage the patient according to it. So for treatment, before providing the treatment, we will do the triple assessment of the patient, and we will exclude the malignancy. And if it is intolerable discharge, then the surgery is the options. Okay. While doing the management of the patient of breast discharge, the following investigations are done, and these are almost common in all type of breast diseases. First of all, the history is taken, detailed history, that is of the family history and past history, and the type of discharge, how much is it, what are the timings, these. Okay, so then you have to do the clinical examination. In clinical examination, you have to look for the breast size and the discharge area, and if the discharge is present at that time, then what type and color. And then you have to do the mammography. This is the best investigation of choice for the case of breast diseases, and ultrasound, MRI, and biopsy, and triple assessment. Triple assessment is a combo of clinical assessment and radiological assessment and histological assessment. Okay, three assessment: clinical assessment, radiological assessment, and histological assessment. So these are the triple assessment types. Okay, so now okay, let's give a revision. So we have the breast introduction, that the nipple discharge is present in the 7% patients referred with breast discharge, and it may be serous blood or strand blood. Now if it is discharged from the surface, then it is eczema or Paget disease. If the discharge is from single duct, that is single duct, then the blood, that is duct papilloma, ductictasis and duct carcinoma, and if it is serous, then fibroadenosis, ductictasia and duct carcinoma. Now if the discharge is from more than one duct, then it is blood, that is duct carcinoma, ductictasia, duct papilloma. If it is blood, then ductictasia. If it is purulent, then mastitis, and if it is milk, then lactation hypothyroidism or prolactinemia. The treatment options are that exclude the malignancy by triple assessment and reassure the patient, and do the investigations which are history, clinical examination, mammography, ultrasound, MRI, biopsy, and triple assessment. Triple assessment is a combo of clinical assessment, radiological assessment, and histological assessment. Then the treatment is provided which is exclude the malignancy, then reassure the patient, and if the discharge is intolerable, then surgery is done. Okay, now the next topic is fibroadenoma. Fibroadenoma is also known as breast mouse, and it is mobile in all directions. This is the diagnostic point. Okay, if there is a lump or mass or adenoma type thing present in the breast and it is mobile, then the differential diagnosis is fibroadenoma. Okay, the diagnosis is fibroadenoma. So we are having a scenario that there is a 33 years woman who came to OPD and noticed lump in breast. There is no nipple discharge. On examination, right breast 3 centimeter lump in upper quadrant, which is hard, non-tender, no evidence of enlarged lymph nodes. Okay. So what are the points? That there is a 33 years woman OPD noticed lump in breast. Okay. No nipple discharges, no discharge, and on examination, right breast, this lump was present in the right breast and it was 3 centimeter lump in upper outer quadrant, which is hard, non-tender, and no evidence of enlarged lymph nodes. There are no enlarged lymph nodes, only there is a lump in the right upper quadrant of the breast, which is 3 centimeter. Okay, so the most common benign tumor of the female is fibroadenoma. We should remember this, that the fibroadenoma is the most common benign, that is non-cancerous tumor of the female breast. Now the clinical features are that it is common in young age, that is 15 to 25 years, and occurs elder age too. But it is common in the, okay, you should remember this, that these type of tumors are common in the young age, but it is also present in the old age. It is firm, rubbery, non-tender, and mobile lump. Okay, and no lymphadenopathy is present along with it. If it was lymphadenopathy was present, then we will go to the differential diagnosis of malignancy. But here in this case, no lymphadenopathy is present, and this is present in 33 years old woman, and also it is mentioned in the scenario that it is non-tender and hard, and no evidence of enlarged lymph nodes is there. Okay, hard, no discharge, and 3 centimeter, and no enlarged lymph nodes. Now what are the differential diagnosis of fibroadenoma? So these are fat necrosis. Fat necrosis may occur, then breast hematoma, and duct ectasia. These are the types of tumors or breast disorders which are similar to fibroadenoma. So the differential diagnoses are fat necrosis and breast hematoma and duct ectasia. Okay, 3 differential diagnoses you should remember for fibroadenoma. These are fat necrosis, duct ectasia, and breast hematoma. Now the investigation options for fibroadenoma are same as that of the breast discharge, that is history and physical examination or clinical examination, mammography, ultrasound breast, MRI, and biopsy for histopathology, and ultrasound guided true cut biopsy. Okay, ultrasound guided true cut biopsy for histopathology. This is the biopsy, this is done for histopathology. Okay. So this is a biopsy for histopathology and ultrasound guided through-cut biopsy. Now the treatment options are enucleation or wide local incision. Okay, wide local incision is given, then lumpectomy is done, that is surgical removal of the discrete portion or lump of the breast. As there is a lump present in the breast, so lumpectomy is done and it is removed. Mastectomy is done for large and recurrent tumors. It is surgical removal of one or both breast. If the tumor is very large, then mastectomy is done. If the tumor is small, then lumpectomy is done. So this is the treatment of choice. So what we have learned about the fibroadenoma, that this is common in the young age of 15 to 25 years, and it is hard and non-tender, and this is mobile, and no lymphadenopathy is present along with it. So the investigation options are history taking, clinical examination, and mammography, ultrasound, and fine needle aspiration, that is true cut biopsy, and ultrasound guided true cut biopsy, and MRI. So these are the investigation options. And differential diagnoses are fat necrosis, breast hematoma, duct ectasia. These are the clinical treatment, that is wide local incision is done, and lumpectomy is done if it is small lump, and mastectomy is done if it is a large breast. Now coming towards the next topic, that is a breast abscess. So we are having a scenario that write short note on the breast abscess. Most of the time this question is repeated in the exam, that write a note on the breast abscess. So breast abscess is also known as mastitis. As we have studied that fibroadenoma is also known as breast mouse, okay? And it is called breast mouse because it is movable in all directions. Now breast abscess is mastitis. Mastitis is the inflammation or infection of the breast. So breast abscess is sequel of bacterial mastitis, and mastitis is inflammation of the breast tissues. Okay, what is breast abscess? Breast abscess is a sequel of bacterial mastitis. It is due to the bacteria, and mastitis is the inflammation of the breast tissues. Okay. Now, what are the causes of the breast abscess? The causes are lactational causes and non-lactational causes. Okay. The lactational causes are Staphylococcus aureus, and the non-lactational causes are middle-aged female who smoke, Streptococcus anaerobes, periareolar, that is periductal inflammation, and peripheral non-lactating breast, and diabetes, steroids, and rheumatoid arthritis. These are the causes of peripheral non-lactating breast. Okay, so what are the causes of the breast abscess? These are lactational causes and non-lactational causes. In lactational causes, Staphylococcus aureus, and in non-lactational causes, middle-aged female who smoke, and Streptococcus, and anaerobes, periareolar periductal inflammation, and peripheral non-lactating breast, and diabetes, steroids, rheumatoid arthritis. These are the features, these are the causes that aid to the breast abscess. So, the female who is lactating, the cause of mastitis is Staphylococcus aureus. In the non-lactating woman, the predisposing factors are smoking and taking steroids, and a patient who is diabetic or she is having rheumatoid arthritis, and she is middle-aged female, and Streptococcus anaerobes, and periareolar, that is periductal inflammations, and peripheral non-lactating breast. These are the causes of the breast abscess. Now, the clinical features of the breast abscess are that there is pain and redness and swelling, and fluctuation is a late sign. Okay, fluctuation is also present as there is a fluid present in the abscess. but this is a late sign which develop after the development of fluid. So these are the clinical features: pain, redness, swelling, fluctuation. Now what are the treatment options for breast abscess? So these are supportive measures, that is breast support and milk should be expressed, and antipyretics, analgesics, and hot fermentation is done. This is the supportive management. Okay, you will provide the support to the breast, and you will take the antipyretics and analgesics, and you will do the hot fermentation, and the milk should be expressed. Now the specific measures are both medical and surgical. The medical measures are that in cellulitic phase, antibiotics, local heat, and analgesia. This is given. The antibiotics that are specifically used are coamoxiclav and flucloxacillin. Okay, these are the antibiotics of choice. And the surgical treatment, when the abscess develop, it has to be drained or aspirated. The method is that gives circumarular incision, better cosmetic result. And EMLA or analgesia is applied 30 minutes before the surgery, and incisional drainage of the pus is done. Okay, circumarular incision, you should remember this, that in breast abscess the incision that is given is circumarular incision, and this is the best cosmetic incision, that's why this is given. When abscess develop, drain or aspirate, method gives circumarular incision, better cosmetic result, and analgesic cream is applied 30 minutes before surgery, and incisional drainage is done. Now the complications of breast abscess are recurrence and infections and delay in healing and formation of antibioma. These are the complications options. Okay. So this is the breast abscess. Breast abscess is a sequel of bacterial mastitis, and it is inflammation of the breast tissue. And the causes of the breast abscess are lactational causes and non-lactational causes. So the lactational causes are Staphylococcus aureus, and the non-lactational causes are middle-aged female whose mouth streptococcus anaerobes, periarular, periductal inflammation, peripheral non-lactating breast, that is diabetes, steroid, and rheumatoid arthritis. The clinical features are pain, redness, swelling, fluctuation, and the treatment options are supportive measures and specific measures. So the supportive are that breast support, milk should be expressed, antibiotics, analgesics, and hot fermentation is done. And the specific measures are that in the medical and cellulitic phase, that is antibiotics, local heat, and analgesia is given, which is coamoxiclav and flucloxacillin. And the surgical measures are when abscess develop, drain or aspirate, then give circumarular incision, better cosmetic results, and analgesia cream is applied 30 minutes before surgery, and incisional drainage of the pus is done. The complications are recurrence, that the breast abscess after drainage or surgical treatment can reoccur, and it can lead to infections. Okay. The delay in healing also occur after breast surgery, and the formation of antibioma can also occur in case of breast abscess. Now coming towards the next topic, that is mastalgia. Okay, so we will discuss the mastalgia, the carcinoma of breast, which is very important, and then we will discuss the thyroid. Okay, mastalgia. Mastalgia. So we are having a scenario that is a 24-year-old who is having 4-month history of intermittent pain and tenderness with the right breast. Pain was before periods and spontaneously resolved shortly afterwards. Examination is unremarkable. Okay. So remember, whenever there is intermittent pain and tenderness and it is related with the periods, for example, it was with the period and it relieves after the end of the cycle. So this is mastalgia. Okay, mastalgia. Okay. So we are having two types of mastalgia. There is true mastalgia and false mastalgia. The true mastalgia actually occur in the breast, while the false mastalgia is from chest. Okay. Now the true mastalgia True mastalgia have cyclical pain, that is 2 by 3rd patients, and non-cyclical pain is 1 by 3rd in patients. Okay. The true mastalgia is actually a cyclic pain, and it is most common. It is in present in 2 by 3rd of the patients. While the non-cyclical pain can also occur, but it is present in the 1 by 3rd of the patients. So mastalgia is true mastalgia and false mastalgia. True mastalgia is present actually in the breast, and false mastalgia is arising from some other areas. Okay. Then we are having the pain. So the pain may be cyclical pain, which is present in 2 by 3rd of the patients, or the patient may be acyclical pain, but it is present in less people, and it is 1 by 3rd. Now the cyclical pain. So the cyclical pain affect the outer quadrant of the breast, and breast is more glandular at the time. Okay. And pain occurs 3 to 7 days before the menses and improves at the onset of menses. This is cyclical pain. And the cause is due to the exaggerated response to normal hormonal changes that occur during menstrual cycle associated with swelling and increased nodularity of the breast. Types of nodes are present in the breast. Okay. So what happens that in cyclical pain, the pain occur 3 to 7 days before the periods, and when periods occur, the pain is relieved. Now the cause is that the hormonal changes occur before the periods, and if there is the exaggerated response to these hormonal changes, then this breast pain occur. And on clinical examination, the breast appear as nodular and tender, and swelling is present. Okay. Now in non-cyclical pain, it is not related to the menses, and it is less responsive to the drug therapy. So the treatment options are that reassure the patient that is after significant disease or cancer, then evening primrose oil is used. Okay, this is the mainstay of treatment, and it contains gamma linolic acid, linolenic acid, and it is fatty acid which modulate the hormone receptors in breast tissues. So the gamma linolenic acid is given. Gamma linolenic acid. Evening primrose oil is used, and it consists of the gamma linolenic acid, and it helps to restore the breast, and it is a fatty acid which modulates the hormone receptors in breast tissues. The results appear in 4 months, in cyclical in 58% and in non-cyclical 38%. Okay. This evening primrose oil is used in both the cyclical and non-cyclical mastalgia, but it is more effective in the cyclical mastalgia. Breast support is provided, that is firm bra at the day and soft bra at the night is used, and danazol is given, which is anti-estrogenic effect, and it is used in severe pain. Danazol consists of anti-estrogenic effect, so it can also be used. The other drugs that can be used are bromocriptine, tamoxifen, testosterone, and gasoline. These are all the drugs that are used for the hormonal effects. The management options of mastalgia is history, examination, and investigations. An investigation mammograph is done for both cyclical and non-cyclical. Then reassure the patient, and for chest wall pain, give severe. If it is severe, give NSAIDs. If it is not severe, then give the simple analgesias, and the treatment course is counseling. Okay. So this was all about the mastalgia. We have discussed the types, that there is true mastalgia and true mastalgia and false mastalgia. Then we are having cyclical mastalgia and acyclical mastalgia, but the cyclical is common. Then we discuss the treatment options, which are first of all, the investigations are done, in which history is taken, clinical examination is done. Okay, so for cyclical pain, uh, it is affected the outer quadrant of the breast, and it is 3 to 7 days before the menses, and the cyclical pain is not related to the menses. This is the treatment option that is reassured the patient. Evening primrose oil is used, and it is the main stay of treatment. It consists glymallinolenic acid. Breast support is provided, and tenazole is given if in case of severe pain. Other drugs are testosterone, bromocriptine, tamoxifen, and gasoline. And the management options are history. Okay, this we have already discussed. So this was all about the mastalgia. Okay, so we have discussed the common disorders about the breast. First of all, the breast introduction, then the different types of breast discharge will be blood and serous, and we can give the differential diagnosis from the discharge. If it is blood, then these are the following types of breast disorders. If it is serous, then these are the disorders, and this is the general treatment: microdetectomy and connexation of the major discretes. Then we have discussed the fibroadenoma, which is also known as the breast mouse, and then we have discussed the breast abscess, which is mastitis, and then we have discussed the mastalgia, which is the cyclical breast pain or any other, and there is intermittent pain and tenderness with the right breast and pain worse before period. So this is mastalgia. Now coming towards the carcinoma of breast. Now carcinoma of breast. So we are having a scenario that there is a 50-year-old 5 centimeter non-tender lump in upper outer quadrant of the right breast for 2 months. Also has firm lumps in the right axilla. So what is the diagnosis, the investigations, the role of chemotherapy and therapy, the assessment, the complications of surgery and the treatment. So here we are having a 50-year-old lady. So she is aged, okay, and the risk of carcinoma is increased in aged people. Then 5 centimeter non-tender lump in upper outer quadrant of the right breast for 2 months. Also has firm lumps in the right axilla. Okay, if there is firm lumps or lymphadenopathy present in the sidewise areas, then this is the clue for the carcinoma. So this is carcinoma of breast. The differential diagnosis are fibrocystic changes or antibioma or fibroadenoma. This may be fibroadenoma or fibrocystic changes or antibioma. Now for the carcinoma of breast, the specific points are that it is 3 to 5 centimeter and no discharge is present, and it is mobile and not attached to the skin, and it is tender slightly, and lumps in axilla is present, and family history is present. These are the diagnostic points for the carcinoma of breast. Okay, family history, lumps in axilla, tender slightly, mobile and no discharge, and mobile not attached to the skin. Okay, so what is the diagnosis, the investigations, the role of chemo and radiotherapy, the assessment and the complications of surgery? All these are the important questions that are asked in this topic. So what is carcinoma of breast? It is a breast tumor which is most common cause of death in female. Okay, carcinoma of breast is one of the most common causes of death in female. Now the causes of the carcinoma of breast are age, decrease at 20s and increase with age. Okay, and at 90 it is present in 20% of ladies, so it is highly associated with the age. Then the family history, that is first degree relatives, it is present in the first degree relatives. And gender, it is 0.5% in male, and it is majorly in females. Then hormonal, the exposure to estrogen and progesterone increase at risk. Okay, if a patient is exposed to estrogen or progesterone, then she is having the high risk for breast carcinoma. Then long menstrual cycle is also a sign, that is early menarche and late menopause increase the risk, and late first pregnancy, that is first pregnancy after age of 32 years, and the pregnancy is protective. Okay, breastfeeding is protective. Oral contraceptive pills increase the risk, and hormonal resistance therapy increase the risk. Diet increase the alcohol intake and increase the risk, and radiation exposure increase the risk. Okay, these are the risk factors for the breast carcinoma. Okay, so the risk increase with these factors. So if someone asks that what are the causes of the breast carcinoma, so these are the among the most common causes, that is increasing age, then the family history, then the use of oral contraceptive pills, then the use of the hormonal resistance therapy, then the okay long menstrual cycles and early menarche and late menopause, and the gender, the hormonal, that is exposure to estrogen and progesterone, and OCPs increase the risk, HRT increase the risk, diet, that is increase alcohol intake increase the risk, and radiation exposure increase the risk, and breastfeeding is protective and pregnancy is protective. So these are the causes. Now the classification of the breast carcinoma. So we are having non-invasive breast carcinoma and invasive breast carcinoma. The non-invasive breast carcinoma are ductal carcinoma in situ and lobular carcinoma in situ. And the invasive carcinomas are invasive ductal carcinomas more than 80%, invasive lobular carcinoma 15%, medullary carcinoma, colloid carcinoma, inflammatory carcinoma, and Paget's nipple disease. Okay, so we have the classification of breast carcinoma as invasive and non-invasive. In invasive, we are having invasive ductal carcinoma and invasive lobular carcinoma and medullary carcinoma, colloid carcinoma, inflammatory carcinoma, and Paget's nipple disease. While in the non-invasive, we are having ductal carcinoma in situ, lobular carcinoma in situ. The spread is local spread and lymphatic spread and hematogenous spread. Okay, so the lymphatic spread is axillary, internal memory, and supraclavicular and contralateral. The hematogenous spread is through bone, liver, lungs, and brain. Okay, so these are the types of the carcinoma of breast, which is non-invasive and invasive. In non-invasive, we are having ductal carcinoma in situ, lobular carcinoma in situ, and in the invasive, we are having invasive ductal carcinoma, invasive lobular carcinoma, medullary carcinoma, colloid carcinoma, inflammatory carcinoma, and Paget's nipple disease. And according to spread, we are having the local, the lymphatic, and the hematogenous. So the local, the lymphatic, and the hematogenous. In the lymphatic, we are having axillary, internal memory, supraclavicular, and contralateral, and in the hematogenous, we are having the bone, the liver, the lungs, and the brain. Now the clinical features of the breast carcinoma. So lump is present, nipple retraction is present, blood stain discharge may be present, axillary lymphadenopathy is present, and bone metastasis is present. Okay, bone metastasis is one of the common metastasis in case of the breast carcinoma. So lump and the lymphadenopathy and metastasis and axillary lymphadenopathy and blood stain discharge and nipple retraction. Now the investigation is assessment, that is triple assessment, in which we are having the history and examination, and then the imaging, that is ultrasound if patient is young, and mammography if about 35 years. Mammography is done in case of a higher age when the breast size is large. If the patient is young, then ultrasound can also be used. The biopsy is used for histopathology, that is true cut or incisional biopsy. And these are the investigation options. This is the triple assessment, that is history, imaging, and biopsy. History, imaging, and biopsy. This is the triple assessment, HIB. The investigations are for the diagnosis of malignancy. We will do the fine needle aspiration and the core cut or true cut needle biopsy and incisional biopsy. Okay, these are the for the diagnosis of malignancy, biopsy specifically used. So we are having the FNAS and the true cut biopsy or fine needle aspiration biopsy, and then we are having the incisional biopsy. These are the three types. Okay, then we are having then for the local extent of the disease, we will do the mammography, the ultrasound, and the MRI. These are the investigation options. Now the important receptors in the management of breast carcinoma are estrogen receptors, progesterone receptors, and HER2 or new receptors. Okay, These are very simple and common. These are progesterone, estrogen, and HER2 on new receptors. Now the lymph node involvement. So the lymph node involvement, yeah, we will do the clinical judgment and the sentinel lymph node biopsy. So for lymph node involvement, the clinical judgment is done and the sentinel lymph node biopsy is done. For systemic spread, pulmonary metastasis, that is X-rays or CT chest, and liver ultrasound or CT abdomen, brain CT scan or bone radioisotope and bone scans, these are done. Okay, so these are the specific investigations that are done in the case of the breast carcinoma. Okay, these are the types. Okay, this is the classification, these are the clinical features, these are the investigation options, and investigations for the diagnosis of malignancy, and the investigations for the local extent of the disease, then investigation for the lymph node involvement, which is clinical judgment, and sentinel lymph node biopsy. And then for systemic spread, we will do the pulmonary metastasis, X-ray or CT chest, liver ultrasound or CT abdomen, brain CT scan, and bone radioisotope or bone scans. These are the specific investigations. Now the staging of carcinoma. So it is TNM tumor staging, TNM node staging, and TNM metastasis staging. Okay, tumor node, tumor involvement, lymph nodes involvement, and then the metastasis. So TIS is the carcinoma in situ, and T1 is primary tumors less than 2 cm, T2 is 2 to 5, T3 is greater than 5, and T4 is involving the chest walls or skin extensions. So the tumor is classified in the 5 classes: tumor in situ, tumor of 1, 2, 3, and 4. So the 1 is the primary tumor, which is less than 2, the 2 is greater than 2 to 5, and the 3 is greater than 5, and 4 is involving chest wall or skin extension. Now TNM node staging. So we are having a node as no lymph nodes are involved, and 1 is palpable mobile involved ipsilateral axillary lymph nodes, and 2 is fixed involved ipsilateral axillary lymph node, and in 3 is ipsilateral internal memory nodes. Now the TNM metastasis stages is M node, which is no distant metastasis, and M1 is distant metastasis is present. So this is the staging of carcinoma. This is the UICC staging, that is at stage 0, tumor in situ, no lymph node, no metastasis. Stage 2 is tumor of less than 2 cm and no lymph node metastasis, and no lymph node involvement, no metastasis. In stage 2, the tumor less than 2 cm, that is T1, and 1, that is the palpable mobile involved ipsilateral axillary nodes, M node, there is no distant metastasis. Stage 4 is the tumor at any stage, that is may be greater than 5 or 7, and the lymph node involvement is there, that is N2 or N3, and metastasis is also present. This is the UICC staging, that is stage 1, 2, 3, and 4. The Manchester staging is for stage 1, a mobile lump in breast, no palpable axillary lymph node. The stage 2 is a mobile lump in breast and palpable mobile axillary lymph node. Stage 3 is fixed lump in the breast with or without palpable mobile or fixed axillary nodes. Stage 4 is the distance metastasis is present. Now the evaluation of axilla. So for axilla, 5 nodes in axilla are described under lymphatic drainage of the breast, and very often central group of the nodes, pectoral nodes, are enlarged and difficult to feel apical group of the nodes. Okay, so usually when you do the breast examination, so there are 5 lymph nodes that are present in the axillary region. So the most common node that is enlarged is pectoral nodes, and the one that is difficult to palpate is the apical group of nodes. Okay, so pectoral nodes are palpable. You should remember this in case of breast carcinoma. If axillary nodes are hard with or without fixity, they are significant. Soft to firm nodes need to be malignant but can be due to secondary infection because of the fungating or accelerating growth. The presence of supraclavicular lymph node does not indicate metastatic diseases. Okay, so this is the evaluation of the axilla. 5 nodes in axilla describe under lymphatic drainage and very often central group of nodes. If axillary nodes are hard with or without fixity, they are significant. Soft form nodes need to be malignant but can be due to secondary infection because of fungating or accelerating growth. Presence of supraclavicular lymph nodes does not indicate metastatic disease. Now the management or treatment. So first of all, the history of the patient is taken, then the examination of for morphology of mass, systemic spread and lymphadenopathy is done, and investigations are done. Management or treatment history is taken, examination for the morphology of the mass or systemic spread, lymphadenopathy is done, and investigations are done. Now the treatment option. Treatment depends upon the stages of the disease. Ductal carcinoma in situ. So ductal carcinoma in situ, partial mastectomy is done, or adjuvant tamoxifen and aromatase inhibitors are done. For lobular carcinoma in situ, lifelong surveillance, prophylactic tamoxifen therapy, or bilateral total mastectomy is done. Now the different treatment options are surgical for stage 1 and 2, breast conserving surgery, resection of the primary breast cancer, and wide local incision or lumpectomy or quadrectomy is done. Mastectomy is done for large that is greater than 4 cm tumor, that is simple mastectomy, extended simple mastectomy, modified radical mastectomy, and Halsted radical mastectomy. Then the radical breast surgery is done. The non-surgical treatment is for stage 3 and 4, that is chemotherapy for stage 1 and 2 greater than 1 cm, and hormonal therapy, that is tamoxifen and anastrozole is used, and radiotherapy is done, and immunotherapy is done. These are the complications, that is complications of anesthesia, which is respiratory depression, arrhythmias, and asphyxia. In all complications, which are hypotension, bradycardia, aspiration, and recurrence. Then the post-op complications, which are hematoma, seroma, wound infection, and necrosis, nerve injuries, and edema of the arm. And nothing harm prognostic index. It is used to determine the prognosis following surgery for breast cancer. The calculation formula is that nothing harm prognostic index is 0.2 multiplied by the stage plus nodes, and S is the size of the lesions, and N is the lymph nodes, and G is the grade of tumor. So 0.2 multiplied by the size of lesions in centimeter, then plus the lymph node, and plus the amount of lymph nodes that are involved, and then plus the grade of the tumor, that is grade 1, 2, or 3. So the interpretation is that if it is 2 to 4.4%, then there is 93% survival rate. If it is 2.5 to 3.5, then it is 85% survival rate, and if it is 3.5 to 5.4, 70%, and if it is 1.4, then 50% survival rate. Okay, so the breast carcinoma formula is 0.2 multiplied by the size plus the number of lymph nodes involved plus the grade of the tumor involved. This is one of the important formulas for the survival rate. So if it is the result is 2 to 2.4, then it is 5-year survival rate.